All right, ready? Okay, good morning, everybody, and welcome to Cardiology Grand Rounds. It's really my real pleasure to have Melissa Robinson speaking to all of you today. I think most of you know her, but for those of you who may not know her as well, Melissa hailed from Sacramento area, but did her electrophysiology training at the University of Penn, ending that in 2010, and then went for 2 years to the University of Illinois being, oh, sorry, am I not doing this right? Oh, sorry. At University of Illinois, where she was director of the clinical electrophysiology services there, and then has been with us for 5 years. And Melissa has really brought a special aspect to our EP program that we really needed at the time, and that was somebody to really build up what we've sort of termed the complex ablation program, but with a specific focus on VT ablation, which is not something that involves just electrophysiologists, but requires an incredible effort put into a collaborative team-building approach to take care of these often incredibly sick patients. So working with heart failure and MCS, the CT surgeons, the LVAD program, it takes everybody involved to really adequately evaluate these patients and manage them and get them into the EP lab where Melissa and others in our group can do such great work. And it's really, I think, changed the landscape for now what we can offer these patients who, as you know, with end-stage heart failure often have recurrent and incessant ventricular tachycardia. Is very difficult to manage. So I could go on to laud how great of a job she's done, because she's really done a fantastic job, and we're really, really very fortunate to have had her join us. But I think I'll now turn it over to her so that she can actually tell you about what goes on with ventricular arrhythmias in the year of 2017 and going forward, and what is VT ablation and what changes that's making for our patients. Thank you, Melissa.
Jordan, this is for you, so you're welcome. Thank you, Jeannie, for that introduction. And it was 5 years ago, last month, that I came and lectured on VT to this group with a 5-week-old to interview for this job, so it's a pleasure to be back here again. I don't really have disclosures that are relevant to the ablation side. Those of you who get the ACC emails, updates, yesterday, Eric Krieger was kind enough to point out that he didn't need to come to my lecture because there were 2 great review articles, so maybe he's home reading them now. I don't see him in the audience, but there is some recommended reading for sort of a background. I was asked to give sort of a review of VT rather than getting too caught up in the weeds. And there's this nice document that came out this year, the 2017 Guidelines on Ventricular Arrhythmias and Sudden Cardiac Death, and Chris and I were both reviewers for that 556-page document, which I'm sure all of you have read. Hopefully you didn't print it out. But there's a lot of helpful information really about the whole spectrum of taking care of these folks. And then 2 nice review articles that literally did come out yesterday that I perused and cover most of what we're going to talk about today with some interesting figures because the lead author is Vivek. But they are a good framework, and honestly the framework that I had set up for this talk. And I want to focus specifically on VT and structural heart disease because that's when we have the most decisions to make and the hardest choices and most difficult outcomes, I think. But it would serve us well to discuss a little bit about VT in normal hearts, so structurally normal hearts, and those tend to be folks that have PVCs, may even have PVC-mediated cardiomyopathy, but the underlying structure of their heart is normal. And once we get rid of the PVCs, the cardiomyopathy goes away. Outflow tract VTs, LV fascicular VT, and idiopathic PVC triggered ventricular fibrillation, which sounds really serious and is, and can definitely cause cardiac arrest, but can happen in otherwise normal hearts, probably a genetic abnormality that we have yet to discover. VT and structural heart disease sort of runs the gamut. We have lots of folks who could be victims of this. The classic model is ischemic cardiomyopathy. I'm going to focus mostly on that, and non-ischemic cardiomyopathy. We have an increasing, it seems, nearly daily in this institution cardiac sarcoidosis patient population, as well as ARVC, hypertrophic cardiomyopathy, and CPVT and Brugada. So we'll focus on those folks. Starting, though, just a few words on idiopathic PVCs. So this is about a quarter of our ventricular ablation referrals. So when we talk about ventricular arrhythmia ablations, about a quarter of them are PVCs, a little lower risk procedure. The lab staff's blood pressure is a little lower as those patients are rolling in the door. And they present with palpitations, fatigue, malaise. Having PVCs, although if you're 20 and you're having frequent PVCs, it sounds like you should be able to muscle through it. It can really take the patient sort of out of their active life and really put things on hold. And the reason that happens can be twofold. You can get a PVC-induced cardiomyopathy. It's probably related to abnormal calcium holding. You get abnormal loads in that post-PVC period, and you can actually, there's transcription factor changes that lead to structural changes in the way the heart actually contracts that can be reversed. And you also frankly have sort of just disordered pulsations here. So this is a patient nearly in bigeminy, but we have a fortuitous beat here that follows 2 sinus beats and a simultaneous art line. And you can see they essentially have a sort of a pseudo hypertension, right? So this is a sinus beat here, and you get a very large pulse pressure here because it follows a compensatory pause after that PVC. Next sinus beat comes in sort of the usual timing, and you get more of sort of their usual pulse pressure. Then this PVC comes in and we have no corresponding pulse because the heart wasn't ready, it wasn't filled, and there was no corresponding output that can be palpated at the wrist. So you get pseudobradycardia and what's called a radial apical pulse deficit. So I get these patients referred for bradycardia sometimes in the primary care or GI office. They have a heart rate of 30, but actually they were in bigeminy. Their sinus rate was 60. So you can imagine how that doesn't make the patient feel particularly good. If the burden's high, above 20% or so, then we worry about that PVC-induced cardiomyopathy. It's very unlikely if the burden's lower. And beta blockers tend to be first line, but they're not well tolerated in young folks, partially because of this and the lowering of the blood pressure, partially because if you lower the sinus rate anymore, they're going to be even slower. And beta blockers are kind of tough to take for some folks. The majority of these come from the outflow tract. They can also come from the papillary muscles. And the outflow tract is really a fascinating region. And I know Dimitri's in the room and probably knows more anatomy than anybody in this room. But frankly, for electrophysiologists, this is sort of our most complicated region. Lots of interactions, overlying tissues, and interplays here. So at the most basic level, just looking at the epicardial structure, you have the pulmonary artery and the RV outflow tract crossing over the aorta and the LV outflow tract and the septum. If we're to take that in cross section, we can see the pulmonic valve here anteriorly and the aortic valve a little bit posteriorly. If we look at this in sort of a more sophisticated CT reconstruction view, and this is done with proprietary software within one of our mapping systems, sort of a cutaway view of the RVOT, they've removed the pulmonary artery that's going to lie over this. And you have the left main coming in the bifurcation here, right over what we call the LV summit. So this yellow dotted line is delineating what's called the LV summit. It wasn't called the LV summit when I was in training, actually. It was just called the LVOT. But this is clearly a region that is arrhythmogenic and seems to be increasingly so. I think we're just recognizing it more so. It's a really complex region to ablate in, you can imagine, as you have the veins coming in, which give you a little window into that area, but you, of course, are crossing over arteries. And in this example, this patient has a very large ramus, intermedius, and you would have to be very careful if you were ablating in that region. It's not an accessible region from the epicardium. We'll talk a little bit about epicardial ablation, but it's not shown on this rendering, but there's a lot of fat overlying all that. So even if we get into the epicardial space, we're very far off the myocardial surface. And from the endocardium, that area is very thick. It's the septum. It's one of the thickest areas of the heart. So to actually penetrate and get at ventricular arrhythmias there can be very challenging. But the sort of silver lining is outside of referral centers like this, most of these outflow tract tachycardias are still, it seems, coming from accessible areas like the right ventricular outflow tract or the aortic cusp. I'm always asked, where's the PVC coming from or where's the VT coming from? So I'll show a few little EKGs on this. And our favorite lead in electrophysiology is lead V1. So it's really important, those of you who put on EKG leads or supervise that you're putting lead. There's Eric Krieger. He's done reading the articles. Perfect. He can give the talk now. So, sorry, Eric. So V1 is that anterior lead, and it's the most sensitive lead to changes in position in the heart. So even if you're off just a millimeter, V1 will expose that. So, and you can see subtle changes in the EKG. So if we're very anterior, where it's labeled 1 here, V1 is right on top of that. So you're going to have a predominantly negative complex with no deflection going towards that. And as we move back in the RVOT and get into the aortic root, we start to have an R wave. And it starts to be kind of more broad when you move into this LV summit region and we get nervous. We say, oh, it's a broad R wave in V1. And people who don't do this kind of work go, what weirdos, what are they talking about? It's really just trying to determine where, from the anterior surface of the outflow tract, where this is going to be located. When you get out onto the mitral valve, which is also a place for idiopathic PVCs, and VT, the periannular regions, then it's predominantly positive. So if we're mapping this in the lab, we spread the EKG out, it looks like this. You can see in this example, we have positivity in V3. We have a little bit of an R wave in V1. This is going to be somewhere posterior to the right ventricular outflow tract. In the right ventricular outflow tract, usually it's positive starting in V4. And we've got our ablation catheter in the heart here, and we're recording signals that are happening 30 milliseconds before the global activation on the surface. And that's because we're near that little single cell that's causing this problem. So mapping focal arrhythmias is a fairly easy concept. Just get to the earliest spot. And it has to be significantly earlier than the rest of the ventricular activation. So in this example, this is a CT rendering merged into our mapping system, and we have the right ventricular outflow tract overlying the LV. If we remove the right ventricular outflow tract, you can see the aortic cusp here, and we have a timing map here. Everything's colored in EP, and white here is the earliest activation right there in the right coronary cusp. The ventricular myocardium that's responsible for ventricular ectopy in the cusps is very low in the cusp, doesn't extend up the cusp to where the coronary arteries are. So generally, we don't need to do an angiogram. Some people do, but we're away from the arteries and can ablate there safely. I don't expect everyone to be able to read this from far in the room, but this is the nice chart that comes from those recent review with Vivek Reddy, talking about VT in structurally normal hearts. Idiopathic VT is here, where catheter ablation really is first line, or you can try medicines. Here's the algorithm for folks that have frequent PVCs. And then over here is idiopathic polymorphic VT, or VF. Oh, that's awesome. Thank you. Good feedback. So right there, so idiopathic VF due to PVC triggers, those patients really should go for catheter ablation. We don't have good medical management. They can have one PVC in a week, and that's the critical PVC that takes them into VF. So suppression of those guys really requires ablation. Thanks, Dave. So idiopathic PVC-triggered VF looks like this on a tracing. This is one of Chris Patton's patients who was recently referred to me. So he has a short run of bigeminy, which is actually not his norm. And he does fine for these 2 beats, but this third time when a PVC comes in after a longer interval, it sets him right off into VF. These are classically Purkinje triggers. It can happen in ischemic coronary disease, especially when you have an inferior infarction that abuts the posterior medial papillus muscle and the posterior fascicle. So you have sort of peri-infarct tissue near the Purkinje system. Purkinje system doesn't like that and tends to act out. So that leads us into VT and structural heart disease. This is what we're normally dealing with. And I'll use this weak pointer to point out. So this is a healed myocardial infarction. So this is an old myocardial infarction. We're looking at the epicardium here that's covered in fat and the endocardium here. This is quite faint. And we've got some fatty replacement here at the bottom and maybe some transmurality right at the edge of our slide there. And we have 2 little brown dots there. So this is a prior ablation with an old style catheter, and this patient hopefully went on to transplant. That's why they have this slide. But this is what we're dealing with when we're dealing with VT in structural heart disease related to healed myocardial infarction, are these little surviving muscle cells within this area of scar. So we think of scar as an inactive substance, but it's not. It still has lots of surviving muscle cells. They're not well coupled to their neighbors. Conduction velocity is slow through those regions, and that allows for reentry. So reentry is the primary basis of ventricular tachycardia in these folks. But not everybody's infarct is the same. So this is actually a really unfavorable infarct, and maybe why we have this slide on this particular patient. So although it's centered on the subendocardium, it goes fairly deep, and it isn't particularly thin in this region. The fact that they were targeting this region means that there was probably electrical activity related to VT circuits there, whereas this more dense, thinned out region, which might be easier to get transmural with our ablation lesions, looks less active. And here's another example. And you can see very transmural infarction here, not very many muscle cells here. And although you can get VT, there still needs to be a critical mass of muscle tissue within the scar that can still conduct electricity in order for you to get VT. And I'm saying electricity, but it's obviously not truly electricity. So what do we know about reentry and scar-based VT? Barriers do not have to be fixed. So I'm showing you this picture as if there's normal muscle and abnormal muscle, and they never change. The normal muscle that's surviving can conduct action potentials, and the others can't. But those barriers change with ischemia. They change with the pacing rate or the cycle length of the VT, and can change with different VTs even within the same amount of tissue or same area of tissue. It requires slow conduction, and that's the basis by which antiarrhythmics, all antiarrhythmics for this really work. They're trying to slow conduction even more such that we can't sustain VT. So in some ways, we're flirting with making VTs incessant by giving these antiarrhythmics, because if we slow it too much, it's going to allow that reentry to cycle around. These are three-dimensional circuits. So I'm going to show you lots of cool maps that we call three-dimensional, but they're actually 2D maps, just displayed in a 3D way. The circuits are three-dimensional, and we're unable to map those currently and really have that fidelity across the wall of the muscle. And there's endocardial and epicardial extensions, and that's clear. Sometimes the epicardium is accessible to us, and sometimes it's not. If you've had CABG, yeah, I could get in there with a needle, or I could ask the surgeons to do a window for me, but there's grafts in the way, and they're going to be pretty adhesed to the myocardium. I might not actually be able to even get to the myocardial surface. So we don't do that too often. And in non-ischemics especially, what is the substrate? It's not a nice healed infarction that we can easily see necessarily on nuke med studies or on echo. These are mid-myocardial scars. They tend to be epicardial scars as well. And there are stereotypic patterns for particular disease processes, but it's quite difficult in non-ischemics. So this is sort of our basic model here, spinning through the scar, maybe out around the edges of the scar, and reentry sets up and you get VT. So first-line therapy for VT for most patients, and for most patients historically, has been antiarrhythmic drugs. And this was even before we had ICDs, right? So beta blockers in all of these patients should be maximized. Amiodarone can be used, but you should be cautious with other medicines that will slow down the heart rate. It may slow the VT like we talked about, can increase the DFT as well. Sotalol can have negative inotropy, so it's not really an option in a lot of our patients. Mixiltine really doesn't have very much data other than the physiologic and pharmacokinetic data, but in terms of outcome data in VT, we use it as adjunct therapy, and there's very little to support monotherapy. There are some novel drugs on the horizon. Dofetilide, which is really an off-label use for VT, but we have used it. The class 1C agents, can you use those in non-ischemic cardiomyopathy patients who don't have SCAR but have VT? Maybe, but we don't generally use them in that population, and we certainly don't use them in ischemic cardiomyopathy patients. And ranolazine. So there was a lot of excitement about ranolazine, and we still do use it as a last-ditch effort. It's a late sodium channel blocker. And when added to class 3 agents, had shown some early promise in small series. But the RAID trial, which has this really cool logo that I thought I would include, so probably got a lot of press. When it was presented, it was actually 1,000 patients, and there was not a benefit shown. And I haven't seen the manuscript for the full study published, but it was presented at HRS. So amiodarone, really the most efficacious drug we have, is the most problematic drug. It's essentially the chemotherapy of the electrophysiology world. And this was a drug that would never get approved in this day and age. It was initially approved for angina and was taken off the market because of the toxicity. But then they figured out it was good for anti-arrhythmic properties, and we got it for a long time really without FDA approval from Europe. And then finally the FDA acquiesced, fine, we'll approve it in the mid-'80s for ventricular tachycardia. But the concerns of toxicity remain there. There's a high discontinuation rate, about 20% a year, and you can see the toxicities here. And I think there's sort of a nebulous toxicity as well, even though neuropsychiatric testing, when it's been done in very small series of patients, is normal. I do feel like there's a lot of our patients who just don't do well, just aren't themselves on it. So it is a primary goal of ventricular tachycardia ablation to really come off that amiodarone in a lot of patients. And it's really not unsuitable to somebody, for somebody who's young and has a lot of years of exposure. But a lot of patients are on it, and when they have recurrent VT, the question remains, shouldn't we just increase the amiodarone? We get asked this a lot. And that was looked at in the VANISH trial recently, which was published in the New England Journal of Medicine, and a lot of our VT literature really isn't published in these broader journals, so I thought I would review it real quickly here. So this was ischemic cardiomyopathy patients. It was done in Canada and the U.S. primarily, although the U.S. had difficulty enrolling patients, so mainly Canadian patients were enrolled. It's about 260 patients, and they were patients who'd had an ICD and had ischemic cardiomyopathy and recurrent VT while on a drug. And they were randomized either to VT ablation by standard techniques or more antiarrhythmic drugs. And the primary outcome was this combo outcome of death, VT storm, or ICD shock. And what they showed is that ablation is better. So the hazard ratio for recurrence of the primary outcome was 0.72 with ablation. And you can see that there's attrition in both arms, mainly due to ICD shocks and not death. So the group, in the sub-analysis, can we just increase the amiodarone? If they were already on amiodarone, the effect of ablation was much more favorable. So increasing the amiodarone, if you're already taking it, really doesn't help. So going from 200 to 400, ablation is better in that situation. If they were amiodarone naive, it was a bit of a wash. So we do know that both of them are effective and that amiodarone is effective for VT. And this was a relatively short follow-up, and so the jury is still out on primary ablation therapy in structural heart disease. So no, you shouldn't just increase the amiodarone. You also shouldn't refer your patients too late, and these are getting cut off. I apologize here, but late referrals for VT ablation really lowers our success as well. So this was 125 patients with structural heart disease, and half of those had VT storm. And we divided them up, and 2/3 were already on high-dose amio at that time. We divided them up to early referrals and late referrals with a pretty generous definition of what a late referral would be. And that's 2 episodes separated by a month. So they were having recurrent VT. Not necessarily 20 episodes. But the median in this group, the mean was 17, a median of 6 before ablation, and 6 months after, our mean was 1 and median is 0. I show this study for a couple of reasons, to say, hey, don't refer the patients too late, but also that our outcomes for VT ablation really should be reported in this sort of way. So we're not going to abolish all VT in somebody with large scars, but what we're trying to do is decrease that VT burden sufficiently so that we can, A, keep the patient out of the hospital, B, decrease ICD shocks that are associated with mortality, and C, hopefully come off high-dose amiodarone, which has its own toxicity. So it shouldn't necessarily be that we're looking at stuff in terms of Kaplan-Meier curves. So this is VT-free survival, and even breaking it up like this, early referrals had better VT-free survival versus late referrals. But again, one recurrent shock versus having VT storm, the patient's still going to declare victory on that procedure. So if we're going to take the patient to the electrophysiology lab, what do we need to do before they come for VT ablation besides just write the order? So we really want to collate all the arrhythmia data. So if there's a 12-lead EKG floating out there at the outside hospital, someone needs to get it. We're going to get all the EGMs off their device, and so we can catalog how many VTs they're having, what the cycle lengths are, what it's looked like over time. Assessment of the hemodynamic status is really important. So right heart caths in folks that are decompensated, if we can do more sophisticated evaluations, that's fine. Claudius has always asked me to put these patients through CPETs, but I think it's difficult to do a full assessment when they come in with VT storm, and that's another reason why these earlier referrals, where we can really get a sense of their heart failure status before we bring them in, can be helpful. And then what we call a substrate characterization. So I'm always trying to figure out where I might be going. So if they have an infarction, and we have that documented on a nuke med study, that's pretty easy. I know the inferior wall's out. That's going to be my target in this patient. If it's a non-ischemic, I really hope they had an MRI before they got their ICD so I can know where their scar is. We can do MRIs in folks who have ICD. There's limitations and you do get artifacts, but there are plenty of studies that do show benefit in that. We haven't done that routinely in this institution, but imaging clearly does play a role in the pre-procedure evaluation of these patients. We need to assess their vascular access issues. So can I even go retrograde in these ischemic cardiomyopathy patients? The gentleman we did earlier this week had included iliac and a stent on the other side that I didn't want to go through. So we need to know that ahead of time, oral anticoagulants and the antiarrhythmics. So rather than pumping them full of high-dose amiodarone when we know we're going to the lab, if we can use shorter acting, shorter half-life medications, that can help our success. And then that substrate evaluation really shouldn't just be catheterization. So it's not that they shouldn't go to the catheterization lab, but there really is a low yield for routine angiography and monomorphic VT. And this is because of that picture that we had looked at before, really. That infarction is there. And although you might have ischemia in another territory, which may lead to PVCs, most VT in structural heart disease isn't necessarily PVC mediated. They have the substrate, they have that circuit at all times, and they just need one wrong timed beat to go into VT. And opening an artery that's remote from that infarction isn't going to change that. This is a smaller study that has yet to be in print, but was presented last year at AHA. 123 patients with monomorphic VT. Half of them already had known coronary disease, and about 40% of them had idiopathic VT, and they all went for angiography. Turns out the yield was pretty low. Only about 9 patients underwent PCI, had an actionable lesion, and 8 of those 9 then went on to have recurrent VT. So clearly open arteries are probably better overall, especially when this patient has concomitant heart failure, but the expectation that opening the artery is going to change monomorphic VT when we have scar sitting there probably shouldn't be the message. So if we're going to go to the lab, what are we actually mapping? So we talked about the focal VTs and just getting to the earliest spot in the outflow tract in those examples. But reentrant VTs are a lot more difficult. So this is a reentrant VT, looks like a papillary muscle VT by the leads that we have. This is our mapping catheter, and we're mapping multiple components, multiple signals here during the VT circuit. And our little cartoon here has this figure of 8 running through this thin channel. And if we have a catheter sitting in the thin channel, we're going to record, because the antenna is large enough, we're going to record signals right under in that channel and stuff on the sides. So we have to have sophisticated mapping systems and, frankly, sophisticated folks at those mapping system terminals annotating for us and working through the systems. And that's going to be activation mapping, which for us in electrophysiology is super fun. You're in the arrhythmia. You're going to characterize the circuit. But you don't get to be in the arrhythmia most of the time. Turns out about 70% of the time, the VTs you induce are unstable. So even with an Impella, even sometimes with a VAD, they're unstable, like we had earlier this week. So you're not able to keep them in it. And a lot of the time you can't induce it. So even somebody having incessant VT, even in the ICU the day before you bring them down, you can't induce it. And that's even without anesthesia's involvement at times. So we do also have to do voltage mapping. You're in the lab and we are mapping what the substrate is electrically in the lab. So this is the 12 lead EKG, and we're on the mapping catheter. You can see we're annotating signals that are actually happening out after the QRS. Right? These are late potentials. These are areas of very slow conduction. It takes a long time to get into that scar, and we can record those signals. Those are potential causes or potential areas where VT can circuit around. And the analogy would be the late potentials on your signal average ECG. This is what we're actually measuring, the little myocardial cells that are creating those late potentials. So we come up with this, a substrate map. So this is a sinus rhythm map. You guys are going to become mapping experts by the end of my talk. So this is a sinus rhythm map. These are not as intimidating as they seem at first glance. So this is the endocardial surface of a left ventricle. You can already tell that it's very bulbous. This is not a normal heart. It's not the nice bullet shape, right? This person has had a large inferior infarction. So you can see the little guy here looking at you. This is an RAO view. And our voltage scale here, 0.5, less than 0.5 millivolts, the size of the electrogram, is scar, and 1.5 is normal. And the rainbows that you see are sort of the border zones. If we tilt this up and look, I can't do this over here. I keep doing that, sorry. So if we tilt this up over here, we can see the detail of the scar. And we make little annotations. The black dots are annotating really cool electrograms, late potential, stuff we want to mark to make sure we go back later and ablate it. And blue stuff may be places we've paced and things were interesting. So in this particular patient, we were able to induce VT. And here the patient's in VT on the right-hand side here. We've got our catheter sitting in a spot of interest. So before we've induced VT, we've made the whole map. We've delineated these are going to be the areas that we're interested in, either based on the electrograms in the lab or based on the 12 lead EKGs or their device. And when we're in VT, these are the kinds of signals we're looking at. So really crazy fractionated signals. You got to kind of, see through the mystery here and find the signals of interest. And that's what we're looking at. Activity, electrical activity that's happening during diastole, when nothing's happening on the surface. That's when the VT's circuiting back around. And at the beginning of this strip, you can see we're pacing, and we're pacing from that spot that we think is really interesting. And I don't see too many interventionalists, so we can put some math up here, and nobody will leave the room. So, oops. There we go. Ha, ha, ha. Oh, there's one. Sorry, Larry. So this pointer doesn't really work here, but the tachycardia is on the right here. So the tachycardia is going at 442 milliseconds. So everything's measured in milliseconds for electrophysiologists, and we're pacing just ever so slightly faster than that. So we think we're in the circuit. We're going to pace just a little faster and see what happens when we come off pacing. Number one, when we pace, it looks the same as VT. So we're using the same corridors to get out of the scar into the rest of the heart muscle. And when we pace, it takes a long time to get out to the healthy muscle. That means we're deep in the scar, or the conduction is so slow that it takes a long time. We're not generally at the border zones. So the border zones used to have a lot of focus, tends to be deeper in the scar where these reentrant points are happening. And the return to our electrogram, our return to our spot, when does the circuit spin back around once I stop pacing, is about the same as the tachycardia. So that means I'm right in the circuit. I'm right where the action is. If I was far away, it would take a long time for me to get in, then spin around, and then come back to me, and the math wouldn't work out. We'd be too far out of the circuit. So we're actually getting out our calculators and doing a little bit of math. We can also see that it takes a long time to get to that surface QRS from my little surface guy. So I'm somewhere deep in the middle of the circuit. I'm not at the exit. I'm not at the entrance point. We have cutoffs for that are suspiciously round numbers, like 30% of the cycle length or 70%. Tells you that these are sort of arbitrary cutoffs. But it helps us guide our ablation. We really want to be ablating deep in that circuit in the critical components. So we come on RF here where the blue arrow is, and because we think this is a great spot, and less than a second later it terminates. So we pat ourselves on the back and we go to lunch. That's not true. So the problem is that that's one spot, and it probably terminated with my ablation because he'd been in it for minutes before, and I came on at a great spot. But it doesn't necessarily mean that that VT can't find another corridor. So I might have been at one vulnerable corridor and then it'll come back. And it certainly doesn't mean that he's not going to have other VTs. So the end of the case looks like this, like a measles kind of drawing. Lots of lesions all over. Thank you. So we need to abolish the rest of the potential substrate. So what's a good VT ablation? I send the patient up to the CCU, and the APP or the fellow says, "Did you get it? Was it a good? Was it successful?" And what I tell patients and families is, it's not like gallbladder surgery. It's not like I come out to the wife and I say, "I got the gallbladder." And I have to say, I think that that's one of the reasons that I'm a little bit lonely in this field, and those of us in the room who do VT are a little bit lonely across the country. It's hard work, and the outcomes aren't firm, and you have to sort of, step back and look at the global picture for each individual patient, because the recurrences kind of get you in the gut, but overall we are decreasing the VT burden for sure. But acutely, how do I decide? How does the fellow decide to put acutely successful VT ablation? Which is always that suspicious, nobody says acutely successful cabbage, but we're working on the nomenclature, on the selling of it. But clearly, eliminating the clinical VT is an outcome that we have to reach, right? Yeah, you can't have the patient still be inducible for the clinical VT that got them to the lab. But we also want to eliminate future VT circuits. Termination of the VT is insufficient. So we need to somehow have, that's been proven over and over, we need to have some measure. And what folks are really moving to is really a complete substrate ablation. What does that mean? I'm trying to get rid of all the potential areas in which this is going to recur from. And if we do that without having the patient in VT, if we have surrogates of how to do that without having the patient constantly in VT, it'll reduce the inductions of VT, and which reduce shocks. So patients do better in the lab. Your patients don't come up compromised. And it reduces the overall procedure time, which is really important because it certainly aren't short procedures. And really, constantly, we need faster and more nimble mapping tools. So I'm constantly bothering the folks that get to ask for stuff. Can we have this tool? Can we have this tool? And they're not just, they're not just for fun and games. The faster we can characterize the substrate, the faster we can get at the ablation, and hopefully the patient won't have to come back. So this is one of the new tools. This is the Arrhythmia mapping catheter, and hopefully we'll get this system in the next year or so. So this is another voltage map, and you can see it looks a little different because we've got about 10,000 points here as opposed to the usual about 500 points with our current system. And they've got a slightly different scale here, but this is an anterior infarction, and there's a huge area of scar here. If we can get the patient, in this case I think it's actually a pig, but if we can get the patient to stay in VT, we can get an activation map. So now the colors mean something different. We have the donut up here. We have a tachycardia at 249 milliseconds, 240 beats a minute. It's hard to map those. It's hard to keep the patient in VT and supported long enough to get this kind of map. So this work is really important when we do get the chance to do that. And what you can see is that there's reentry through this narrow corridor here in sort of a figure of 8. It can go around both sides and come back in. And it's really hard to tell that from here, right? Like, how are we going to guess that this is the critical area, at least for this one VT? And we can also demonstrate that you can spin back around the other direction in those VTs. Rod Tung was kind enough to give me this. This is from a system that we newly purchased, and I haven't, I did my first case on that system this week rather. And this is an epicardial map of a patient with a healed myocardial infarction, and they'd already had endocardial ablation. And we're tilting up, we're looking at the apex here. We're in VT. The endocardium has some interesting signals here, but it's really the epicardium where this is breaking out and where this turnaround point would be. And it's deep in the scar, and when we can get these maps quickly and not leave the patient in VT for a long time, we can target these areas and at least get rid of that one VT and any VTs that might be using that corridor. So there are times when we can't get it, and what can we do in those circumstances? And we'll talk about that. Actually, I'm going to skip that for now because it comes up later. But there are times where we need to go to the operating room. In this particular patient that we were talking about before, there's an inferior wall infarction here. And I get this to play, I hope. Oh no. So the inferior infarction's here, and if this were to play, which it's not going to, you would see that the heart overall really is not moving. And this is our ablation catheter, sort of lonely in the center of the giant, almost New York apartment size left ventricle, and those are patients that are going to need to be supported during their case. So the ejection fraction is one cutoff, but really we need to be more sophisticated about it. So can we predict acute decompensation during VT ablation? This is an interesting study out of Penn where they tried to develop a scoring system, and it's about 200 patients. 10% of their patients had acute decompensation. That's high in the lab. And that's definitely a higher number than we have here. And having worked there, I can tell you there's various reasons for that. But what they found to be associated with decompensation was age, diabetes, New York Heart Association class, the ejection fraction, whether or not they had COPD or ischemic cardiomyopathy as the etiology, and whether or not they were in VT storm. And the use of general anesthesia, and I've highlighted that for any anesthesiologists who might have gotten lost and came in the room today, but general anesthesia is a really big problem. So 60% of risk of decompensation, 60% of their patients decompensated who'd had GA, rather, 60% of the patients who decompensated had GA versus 29%, and that was highly significant. Procedure time wasn't significant in their group, but we'll talk about that. So they came up with this scoring system called the PAINIST. It doesn't really roll off the tongue. And it's probably why we're not using it. Plus, it has the word pain in it, which don't really want to associate with VT ablation. So, but you get the idea. And the risk is pretty high. If you get a lot of points here, your risk of decompensation is 25%. Those are patients we either shouldn't take to the lab. We should tune them up a lot more before they get to the lab. We should really understand their hemodynamics, or they should come in already on support, or certainly get support before we do anything other than get access. It's important that we're efficient in the lab, and this is a study from the UCLA group, about 150 patients. Half of these folks had STORM and half had ischemic cardiomyopathy. And this is total time in the lab here. And the colors represent whether or not they were just endocardial ablations, the dark blue, UCLA colors here, or endo-epi mapping in the light blue. Epi only is the rare cases. And you can see that our sort of mean times are in the 5 to 6 hour range. It's quite a time investment. And some of those procedures are running longer out here. If we adjust for the patient's baseline comorbidities and covariates, the longer the procedure, the higher the in-hospital mortality, not 6 month, not 12 month. And if you adjust for intraprocedural covariates, like whether or not they had a support device, whether or not you induced VT multiple times, then that also is significant. So we have to be fast. It's just true. We have to be fast. And so we have to have fast tools. We have to move efficiently through the non-exciting parts of the procedure, like access, but safely. So in this institution, we're sort of carefully selecting our candidates and considering pre-procedural placement. The interprocedural targets for this are really evolving. Should we be following mixed venuses? Should we be following PA pressures? What should we be following to say, hey, enough's enough. We can stop the procedure and live to fight another day. There's very little data to support the use of it. It sort of just came online and we've started using it. And there's increasing numbers of these being used. So the peripheral VADs, this is a Medicare population sample. PVADs are increasing even over the last few years. Intra-aortic balloon pump use is really going down. It's not sufficient support for these folks. And despite the increasing, or because of the increasing use of PVADs was the proposition here, mortality is actually lower in that group. You'd think, oh, you're selecting PVADs because those are sicker patients. They had a lower mortality, and even the patients that ultimately developed cardiogenic shock had a lower mortality. So a signal there that they improved. We're using the CP for the most part. The 2.5 really doesn't support them enough. Very few patients are going to need a 5.0. And the reason is the 5.0 has a lot of magnetic interference with our current mapping system. So I really try to tend to avoid using it. Here's the data, and this is a busy table, so I'll help you guys out and hide all the non-controlled data. So 3 studies had any sort of controls, about 80 patients, and all they could say is that you could be in the lab for longer. So I just told you that we don't necessarily need to be in the lab for longer to get where we want to be with patients. So it doesn't mean that every patient should have a PVAD. It means that we shouldn't use general anesthesia. We should pick our patients carefully and maybe do 2 procedures that are shorter instead of a 9-hour procedure. I'd be remiss if I didn't take the opportunity to talk about ECMO. I really think that this is where a lot of our patients are going to be served best in coming to the labs. We haven't done a lot of this here, but there's quite a few patients I certainly think who would benefit from being on ECMO for the procedure and better support, and probably do that increasingly in the future. Also, no interaction with our mapping system, right? All the hardware is external. Certainly adds a layer of complexity to the procedures, though. So how good are we? So this is a really amazing effort on the part of the UCLA group. We're the ones who organized it. And so 10 centers, and we recently joined this coalition. It's the International VT Consortium. And there's about 2,000 patients in the database right now. And they looked at the patients with ischemic cardiomyopathy and non-ischemic, so structural heart disease in these VT ablation patients, and looked at survival after VT ablation. And this is really what we're fighting with these patients, is the underlying disease process as well. So if you had ischemic cardiomyopathy but your EF was relatively preserved, didn't even matter how good we did. You might recur and you have essentially the same outcomes. Non-ischemics are a little different. They don't do well as well with recurrences. And this is also transplant-free survival, so there was a higher transplant rate in the non-ischemics because they tended to be younger. But that's not true if you're sicker. So if your EF is lower and you recur, whether or not we can intervene on that and actually do a better VT ablation is more of a unanswered question at this point. There may be patients we just can't get rid of the VT for sure. But those that did not recur did much better in terms of their survival, and this is over 12 months. Those that recurred did not do well. You can see that survival curve drops off. Other insights, this is analysis that Wendy Zhou did from the same group of patients, just showing that even in class 4 patients, they do benefit from ablation, but if they do recur, those class 4 patients, so another slice of it, not just looking at EF, those patients don't do well. So the stakes are even higher the sicker the patients are. So how can we predict this? How can we do this moving forward? I'd be remiss if I didn't talk about the Seattle heart failure model in this audience. So this has been looked at in a VT ablation population between the Minnesota VA and UCLA, and they used a modified Seattle heart failure model, and the modification was they added VT storm as a risk factor. And dividing this into quartiles here, the higher your Seattle heart failure model risk score, the lower your survival was, irregardless of any of the procedural aspects. So they weren't looking at anything of what they did in the lab. So there's sort of an independent process that's happening while we're trying to quell the VT. So how good are we actually at just getting rid of the VT? These are the kinds of plots you see when you look through the data. So this is the original Thermocool trial, and median events were 12 before ablation, and 6 months later the median was 0, but there's quite a few recurrences at the bottom there. SMASH VT is a primary prevention study in the sense that the patients really hadn't been treated for their VT. They didn't even have an ICD yet, but had had a single episode generally of VT. And ablation did show a really strong signal for improvement here. Those patients had really, both in the control group and the ablation group, a much lower recurrence. VTAC study is a more traditional ablation setting in the sense that patients had already been on antiarrhythmics and failed those, but again, still ablation showing that benefit. So the overall meta-analyses are coming in. Now we have enough data, and really the effect of VT ablation on recurrent VT is positive, obviously, or I wouldn't have a job. The overall interaction is there. And for antiarrhythmics, it's really not. So this is amio at the top and sotalol here in the middle. Salivarone showed no benefit in the large, really large trial that was done, and Zimmelide similarly. So the overall effect is non-significant for antiarrhythmics. However, it is positive for amiodarone, so it is effective for amiodarone like we talked about before. But this is the signal we kind of really care about. Amiodarone has a signal that suggests maybe some harm here for mortality. And ablation, we haven't been able to prove that we can prolong lives there, but there is a suggestion there. So this is sort of the holy grail for VT ablation. It does not improve mortality, and amiodarone may increase it. I think in the interest of time, I'm going to skip some of these because I talked too long. I had to bail out. And so this is, again, a busy slide from that review article, but talking about management strategies for sustained monomorphic VT. And these are reiterated with the recommendations in the current guidelines. So it's a strong recommendation for taking the patient for ablation when you have recurrent VT. So what if we can't get it? This is a recent patient. I'll finish with this patient with sarcoidosis and recurrent VT. He's got an ugly looking VT. When we look at that lead V1, he's got this really deep negative deflection, kind of looking like a septal VT, positive in 2 but negative in 3. He'd had a couple prior ablations endocardially because this was in the middle of the septum, not epicardial. He'd had a sympathectomy and unfortunately recurred. And multiple different morphologies at the basal septum. This is that bipolar map that we've gone through before. So this is the left ventricle, and this is the right ventricle looking at the septum. Just some minimal abnormality here at the base, but when we look at the unipolar electrogram, so displaying it a little bit differently, helps us look sort of deeper into the septum. We can see abnormality really deep in that septum. So I call my colleagues because this is really all I can do. This is a fresh lesion in a patient that went for a TAH, actually. That's as far as I can get, even with our strong settings. And when we have mixed myocardium here, the transmission of the radiofrequency energy is even less predictable. So how do we get deep? Well, I call the interventionalists who I was picking on before. I don't ask them to do math. I just ask them to do angios. And we've got a balloon in the septal artery here, and we're blowing this up and injecting cold saline. If it terminates the VT, then we know we're on to something, and we inject alcohol. So I think on that note, I will end. And I have some additional, I'll try to end. There we go. I just wanted to thank all the people that I collaborate in the group. I certainly couldn't do it without all these folks. Thank you. Questions?
Fantastic. I learned a lot also. Thank you all. But we do have time for 1 or 2 short questions before we have to start vacating the room. So,
Finley.
For pulmonary toxicity, you know, we're always looking at DLCOs and they drop a little bit, or the patients had a crackle or two. Is there some very straightforward way to prove that they don't have amnio-related toxicity?
No, I think it's a really good question. 3% is truly interstitial fibrosis. So on that slide. So I think in the studies that I've looked at, and certainly my experience, it's on the order of a third of patients who have a drop in DLCO. And we often look the other way because VT is such a formidable obstacle. And that's why I push forward every day to try and get better at mechanically getting rid of these VTs or understanding what's happening. Because I think the number's quite high. DLCO is the most sensitive, and we do follow it. And one of the problems is when we started in the hospital in the heat of the moment, we don't honestly get a baseline in a lot of these patients. And so 6 months later, someone remembers, and we look, and yikes, they started out with a DLCO of 46% or something. So I think it's a really good point. Carolina. Yeah, so the question was, and you know, honestly, I could talk for another 5 hours. I think you guys realize, but the question was, how do we introduce sympathectomy? So the biggest study actually was recently published, and Jack Marmar-Visegi put that group together as 125 patients. And showed an important decrease in ventricular arrhythmias in those patients with bilateral sympathectomy. So not anywhere near as strong of a signal with just left sympathectomy. And I think the physiology behind that is fascinating. We've done about 10 of them here, 8 or 10, and we've been using them as last-ditch efforts, frankly, like after definitely repeat ablation or first ablation where we know that the substrate's inaccessible. It's really deep septum and there isn't an artery that we can ablate. It's epicardial and we can't get to the epicardium. So it's definitely second line. And I think that our outcomes here are good. They do it for sweating. They do it for hyperhidrosis. So if your patient is in good enough shape, going through the procedure is really not such a big deal. The risk is obviously Horner's. And the problem is if they don't quite get enough of that stellate ganglion, then we're not going to get the benefit that we want.
We have to cut it off because I'm getting out of the room, but Melissa will stay up here and can answer any other questions.
Oh, yikes.
If you want to come on down. Thank you very much.